Quakes, although Roxana's attending. Welcome, Roxana. Nice to see you. Richard Parker, Leslie Dabell, who's unwell. Thought she might be able to attend, but when I last spoke to her, I didn't think she would. So if she doesn't, I understand that. Greg Fell, unavailable. Lisa Phillips is running in sick this morning. Mark Brooks is online. Mark, welcome. Nice to see you online. And Cassie is coming, but is stuck on the M1's been an accident. So if she comes in the middle, that's fine. We are still quorum, though. Is that right? Thank you. Any declarations of interest from? Okay. Thank you. Minutes of the last board meeting, 7th of January. Are they okay? Take silence as a thank you. Thank you. Needed someone like that. Thank you, David. Action log. I mean, can I say that the action log looks a bit bloody open? Pardon? It looks a bit open to me. Can I ask the various people to sit and work with Mark? I think most of these can be closed. This is an ever-growing list, which doesn't fill an LCO like me with any degree of warmth. So if we could just close that down, that would be really helpful. So thank you. Right. Storytelling.
Thanks, Ian.
Marianne.
So Katie's prepared the storytelling this morning. Normally what we hear about is when some of our citizens have challenges in accessing some of the services that we commission. But what we're going to hear about today is actually where some of our developments are really starting to make a difference in terms of people being able to access our services differently. Before we put on the short film, I'm just going to ask Katie to say a few words around the development, which is the Health on the High Street in Barnsley. That's okay.
Thanks, Mariana. So, Barnsley Health on the High Street puts health firmly at the heart of Barnsley Town Centre's reimagined town centre. And the idea behind it is making health as easy to access as possible. And at the same time as somebody coming in and accessing their health, they can get coffee or pop to the market or go shopping. And they can park. So there is obviously a short video that will talk about the latest opening on Health on the High Street, which is the ophthalmology department that has relocated from the hospital. This is phase 2 of the work. Colleagues around this table will be aware of this, but phase 1 of the work was the location of the Community Diagnostic Centre in what is the new town centre, the Glassworks within the Alhambra. And again, that was a very deliberate act between the hospital and the council and partners to try and make screening, which is something we really have struggled with in Barnsley for a lot of years, very accessible. The results of relocating that have been significant. So a real increase in uptake rates, so 22% increase, for example, in mammograms, and a 24% reduction in people not to their appointment. So based on that, the hospital were keen to keep going with the outpatient redesign. And what we think we now have in Barnsley is probably the largest relocation of an outpatients department anywhere across the country. We'll hear about ophthalmology today, and they will also be relocating dermatology and a couple of other specialties. So anything that isn't an acute outpatient appointment will be done in the town centre, which works really well from their point of view, because it keeps the activity flowing through that in spite of the noise. Third phase, which I won't talk about, is to create around both of those 2 phases something called a health and wellbeing hub, where we're looking at locating a lot of the adult social care services, the broader council services around pathways to work, healthy homes, family hub, and the voluntary sector around that whole location as well, linked into our 6 neighbourhoods. So I'll shush now, but I thought the context might be helpful. Could we go to the videos?
Hi, I'm Colin Wilkinson. I'm a hospital volunteer, but I'm also a patient of the hospital, and I've been a patient for about 10 years at the ophthalmic department. I go there for retinal screening because I'm diabetic, and also I've got macular degeneration, and I've been going there for about, as I say, about 10 years. Originally at the department of the hospital, which always seemed a little bit frantic and a little bit chaotic. And this new department down here in the Alhambra is quite different and very, very welcoming. location is very important. I mean, there's always issues at the hospital about parking, and you get in the queue in the traffic to get into the car park and you miss your appointment, or the concerns people have got about where do I go in the hospital, which department. In the comments are often from people, it's a rabbit warren, I can't find my way around. That isn't the case here at all, because it's smaller, it's compact, it's straight to the point. It's also familiar because you're in the town centre, and for a lot of people that's a much more familiar environment than having to go over to the hospital. Well, obviously access is an important thing, and this is very accessible. I mean, it's great really, and I think it's for the patient that's very important. Accessibility and ease of access, but also being able to do other things. If you've got an appointment at the hospital, you've got to get to the hospital and then you go home. If you come here, you're coming into town, so you can do other things. You meet your friends, you can go for a meal or coffee, you can have a walk around, see people. It's more of part of your normal day. I think the move here will benefit patients by the ease of access and being part of their normal day. They can do other things, and it feels less medical, which I know is a ridiculous thing to say when you're coming to a clinic, but it does. It's not a hospital atmosphere, it's a much more relaxed atmosphere, perhaps more patient friendly. I would put it that way, I think.
Thank you. A couple of things I'd say. So I remember not long after I started, I was harangued by Sir Steve, the leader of Barnsley Council, who walked me around the Alhambra, literally, it must be about 3 or 4 years ago, and said, this is what we're going to do with it. It's just fantastic to see that, and it was great. The other thing, when the CDC opened, again, I came for a walk around. And what was interesting is, and anybody who knows Barnsley Town Centre knows this is not just about health. The economic benefits for Barnsley Town Centre of thousands upon thousands of people going in every week is phenomenal. And I was bullied into walking around the market, and the market traders were telling me that actually we have a responsibility in health on economic development, not just to provide health. And it also allows the hospital then to think about using that space better and differently. And if you look at the problems many of our acute hospitals have, really bad car parking, very compressed sites, departments that aren't in the right place next to each other, they need to create space to allow that to happen. This is a great example of that. And I just think it's some of the best work I've seen in my time in South Yorkshire. And by the way, great tribute to Sir Steve, who has a real vision of what Barnsley should look like. And if there's ever an example of when civic leadership makes a difference, I would say it was Barnsley. And that really good stuff. Any other points people want to raise? Kevin.
Thanks, Chair. I've got a couple, but I'll take them one at a time. So I think it's great stuff, this. And I'm just taken by something Colin, I think it was Colin, said about it being more patient friendly. And I was just conscious that it was 2 or 3 meetings ago, we were sat in this very room, and the patient story was a focus on the deaf community. And it just prompted me to think in terms of when we're designing these services, we've got the opportunity to almost have a blank piece of paper. To what extent do we build inclusion in when we're designing these services?
Yeah, please, Katie, sorry.
So I think you're absolutely right. And I think they offer an opportunity to build it in from the beginning. So with the design of the outpatients and actually the community diagnostic centre, we have architects who we ask specifically to build inclusion in. So some of the examples of that are that actually there are really clearly colour zone areas that people have to go to. So if English isn't your first language, or if you have issues with being able to read or write, actually you can quite easily navigate your way through these facilities by saying, actually just go to the purple zone and stay in the purple zone. The other thing that especially the ophthalmology department is using is something where there's basically a no waiting policy. So it's just in time appointments. So if you've got one of these, what it will essentially say is it's time for you to come for your appointment now. You walk in and actually the flow is such that you don't sit and wait in waiting areas for long periods of time, which again, I think really helps people when they've got other things they might want to do with their day. And what they found with that, obviously, is that it means that they're not building up kind of long queues of people waiting for different things. So inclusion's very much built in at the beginning. And I think the way in which the layout is able to be designed, I mean, the ophthalmology department, you wouldn't know it, doesn't have any natural light. When you go in there, it doesn't feel like that at all. So I think it's been brilliant. It's been brilliant to be able to do that right from the start.
May I just follow up on
Yeah, please.
particular point? So I get that, and architects usually are quite gifted at understanding some of the nuances. But I just wondered the extent to which some of those communities have been engaged in the design itself directly.
Yeah, so there's a very active user group in ophthalmology who have been part of the design of that. And they've had to do, I guess they've done 3 bits of really significant engagement. The users of the service have helped design how it looks and feels and flows, and talk about some of the things that haven't worked well in the hospital. And I think the other community that they've done a lot of work and engagement with is the clinicians, because obviously they're working there and they know where some of the rub points have been. So they've brought those 2 groups together, but it's very much been co-designed with people. This one.
Thank you, Katie. Thank you,
Kevin, thank you. Any other points people are raising? Okay.
I just want to again congratulate you on what you've done, because that's exactly what patients need. It's somewhere that's accessible, so within an area that they're familiar with. And I'd really like to see Rotherham are doing a similar project on health, and I'd like to see that kind of thing replicated there.
Look, I think this could be operated in all our town and city centres, couldn't it?
Yeah.
No question of that.
Proper neighbourhood
Yeah,
health.
most of our sites, most of our acute sites in particular, not exclusively, are too busy. They haven't got enough car parking. You can see people arriving, getting stressed to arrive at their appropriate clinic appointment. This helps those problems enormously. I agree, Jane, can make a real difference. Any other points people want to raise? Yes, thank you. Thank you for that. Really, really helpful. Really good story. Chair Matchett, a couple of things. You will have got my note that I'm due to fit. My contract was running out at the end of March. I have agreed with the NHS England I will stay till the end of June, which effectively sees out the bulk of the changes. And you need to know I have also told them that's a hard stop. So I am in conversations with them about the process for appointing the next chair to give them, but I've given them the time to do that, I suppose. First, Chief Executive.
Thank you.
Please.
Morning, everybody. So, quick update on the report. See, you've got the written report. I'll pick out the highlights. So, first one is the national changes to the Integrated Care Board, which obviously the organisational change to us. So, I know you all know this, but I'll just re-summarise. Is our consultation period ended at the end of January. We were legally required to do a 54-day consultation, but because it fell over the Christmas period, we extended it to 66 days to make sure that we could follow the process to completion, and we agreed all that with the trade unions. As part of the process, we had 300 informal resolutions which were submitted. And so what we did is we set up panels which gave responses to the informal resolution process. And that's gone through with individuals and been communicated back. And then we've had 1,000 general feedback, but when we've had the general feedback, what's been really helpful to inform our final structures, but also to inform our target operating model and how we work. Our staff gave us some real insight into how we can work it better than in the original proposal. So when we get the final outcomes report and the target operating model, you'll see that it's very much evolved as part of this feedback. So I think the date's 11th of March, where we receive the final outcomes report, and the target operating model will be produced at that stage as well, so the board can consider that. Then we move to final sign-up if the board thought appropriate, and then we move to implementation of populating the structure with the next step. The headline figures are for us, we had approximately 850 whole-time equivalents, we'll be reducing to 510, and that's a loss of 340 posts. In terms of voluntary redundancy, in the first round we had 150 voluntary redundancy applications approved. Obviously they'll not convert until there's final sign-off by the individuals, but we made offers to 150 members of staff. The intention will be then to reopen voluntary redundancy for a short period when the final structures are published. My instincts are telling me we'll probably end up with about half voluntary redundancy and half compulsory redundancy when we get through the process, but based on previous exercises. But hopefully we can maximise voluntary as part of that. Just to reiterate, we've had a lot of feedback from our 4 places, just looking for reassurance that we'll maintain our place relationships going forward. We will have place relationships that will be clearly outlined in the target operating model. It will work in a different way to previously because we will have South Yorkshire teams that work into place in a different way, but we'll make sure that all our functions are discharged and our relationships are maintained as part of our way of operating. And the way I would say to people, what we're looking for is we're looking for a transition period between April, May, June as we start to get there. And the 1st of July will be almost like the launch date of the version 2 of the ICB as we go forward. And at that point, our new structure will kick in, but also our new governance arrangements or revised governance arrangements will come into operation as well. Okay. Just pause if there's any questions on organisational change.
And just remind non-execs we've got a transition committee after the board, or 15-minute gap, and that is upstairs, by the way, guys, not in this room here. Okay.
On the finance position, Roxanne will update as part of the finance item on the agenda. But just to reiterate, we're looking at a year-end deficit of 39.7 million. As we get near to year-end, the risks are diminishing, so we can. I think we're getting quite a high level of confidence that that should be achievable. In terms of efficiency plans, we've made our significant efficiency plans, which we have achieved. There's been cost pressures, particularly in right to choose, continuing healthcare, and weight loss drugs, which have been up the areas of overspend, which we haven't managed to mitigate. In terms of medium-term planning framework, so we're in the throes of the planning round. We have a 1-year and a 3-year plan, which we have to submit. The good news is this year we're planning in February, March time. It was later on last year, but obviously it's a very challenging environment we're working to. With a 2% uplift on our allocation, it's not enough to cover NHS inflation. So we're having some really challenging discussions with our providers, and the South Yorkshire providers are working with us to try and make sure that we can deliver the national asks on access and targets, as well as deliver financial balance. So that's what we're working through. There's an expectation that will be finalised before the end of March as we move into the next financial year. In terms of the ICP development, so we've been having discussions with all our partners at Simca and the local authorities, and we've been working through the ICP. The key focus has been the working together pathway and the collaborate in terms of value and support to the workforce. That was the key thing for the meeting last time, particularly related to the voluntary community and social enterprise sector and developing a diverse workforce. In terms of the ICP, we will bring it to a future meeting, but there are plans to evolve the ICP as we move to our new way of operating. So, Chair, we're bringing that to a future meeting, but we still do have to have an ICP, but there's a recognition that it can evolve into sort of the next phase of working, something which is finalising with the partners. Dr. Prime, I think you wanted to update on industrial action.
Just we had it captured in the report that resident doctors have an extension for a further 6 months. Now we haven't got any dates announced at this time, but we're conscious that that has impacted on services. And then last week, after we published the papers, the GP contract was announced, and GPC England are holding a referendum that starts today to the 25th of March for all GPs in England, because they feel that the contract changes have been imposed, asking the government to look at a new contract. So Anthony's the exec primary care, but I'll certainly help support him and watch how that evolves and what the impact of that may have. Thanks.
And just lastly, just to flag up that the cancer strategy was launched by the government, which is looking for 75% of patients surviving cancer for at least 5 years by 2035, which is also something we'll be really ambitious and keen to work on. And the other thing is the place updates, but I'm going to leave that to the place directors to do at this part of their plans.
Any questions for Chris? Thank you. Andy, I think we've had one question from a member of the public.
Yeah, that's right, Piers. We've had a question from Neil Calderwood on behalf of No Palantir in NHS South Yorkshire. So I think colleagues may remember we've had a number of questions on this subject in the past. So if it's okay, he's provided a commentary which we'll post on our website, but I don't propose to read out. He's asked 3 questions. I'll take each in turn. So he just asked what progress we've made in adopting the federated data platform. And the answer is that, like other ICB's, NHS South Yorkshire owns and maintains its own secure data platform in addition to the FDP. This platform is used to undertake analysis of data to support commissioning and evaluation of services for patients. We are signed up to the pilot for the strategic commissioning tool within the FDP, and tool supports evidence-based planning. So secondly, Mr. Calderwood asks around, given the fact that the FDP isn't mandatory, and he notes an example where Greater Manchester have taken action, should we pause? And the answer is that there's a national expectation that NHS organisations utilise the FDP and move to a nationally provisioned infrastructure, and that's set out in the national guidance. At the moment, there's been no formal adoption process for the FDP. Its usage is as a data source, so we'll post a full answer to that. And then thirdly, he asks if we could arrange a meeting with members of the board to discuss the concerns in detail. At the moment, given what Chris has just outlined about the organisational change, we don't have capacity to meet with the group at the moment regarding this matter. That may change in the future, but I think given the fact that the pressures on colleagues around this board on the organisation change, we just don't have time to meet with them at this moment.
Okay, thank you.
Let's get that just out.
Please, David.
But what we've done as a result of the number of questions we've had is we've got an FDP explainer that we're going to put on our website. So it'll give much more information about the background, how we interact with it, because I think we're getting caught up in between something that's not actually, we can't influence.
I mean, the issue here, clearly, and everybody will understand this, is there is genuine political concern about FTP being used by the NHS in general. And that's an understandable point for people to raise. However, we're part of the NHS and we need to do what we need to do. The truth is, it's not been picked up very much by very many places yet. But if we put that on our website, it'll be clear.
And just to confirm, that is now live.
Okay, thank you. It's up. Okay, thank you. Thank you for that. Item 9, Board Assurance Corporate Risk Register. Wow.
Thanks, Chair. I'll take the report as read. The Board Assurance Framework and the Risk Register is presented to the Board for consideration and approval. We've summarised the range of governance meetings that the documentation has been and risks have been considered in. I would just note that we are now working to close down the 25-26 Bathroom Risk Register. We'll do that over the course of the next few months with the objective of setting up and standing up a revised Bath and Risk Register that reflects and is aligned with the new organisation from the end of Q1. The board will be engaged in the sign-off and the formulation of those top-level strategic risks, and obviously the risks that are within the register that will simply transfer, we will do so, we'll transfer it.
Okay, thank you. Okay, we will need, we've talked about this before, we're planning to deal with this in the April informal. We will need a revised board structure and a revised corporate governance structure, and falling out of that then a revised risk register. We hope to bring that informally to the board in the beginning of April. That will require changes to our constitution, which actually require a bit of formal approval at the centre. It's changes all ICBs are going through. And falling out of that will be a revised governance structure, subcommittee structure, if you like, and also clearly a revised BAF, which, back to Chris's description of, we see April to June as being moving towards a new structure, operational from the 1st of July. In a sense, that's part of this one. Any questions on that? Thank you. Commissioning the strategic commissioning plan. Emma, are you?
Yeah,
Thank you.
okay, so thank you, Chair. So thank you. Yeah, so the item today is just to present our final draft strategic commissioning plan that was submitted to NHS England on 12th of February as part of the overall planning pack. What I'd say that I think that this is the first one that we've done. The future of commissioning must shift from managing demand to addressing the underlying needs of the population. I think our strategy must be rooted in population insight, ensuring our priorities are set based on potential greatest impact. We can't do more of the same. This needs to be a radical reset. This is our first strategic commissioning plan and it's transitional. It's very high level. I think we agreed that the last meeting would be pretty pragmatic in our approach. But I think this can't be about additionality. This isn't about saying we need more. This is about saying what we're going to do with the money that we have over the next 5 to 10 years to make sure we shift our resources to make the 3 shifts in the 10-year plan and to make sure that we start to embrace neighbourhood health in a way that we really need to. We've talked about it today. Katie's given some great examples of what we're doing in Barnsley, but actually how we're going to do that. So I think, you know, it's going to be very different in terms of just kind of listing the things we'd like to do. It's actually thinking about what can we do and how we're going to demonstrate to our population that we're really starting to improve outcomes and using our resources in the most effective and efficient way. So that's the kind of overall steer. Marianne will take us through the detail and I'm happy to answer any questions at the end. Thank you.
Mariana.
Yeah, so I was just going to pull out just a couple more background things that means like planning comes. So if you remember at the board in development session in December, that's when we kind of acknowledged that we've got the guidance to develop a strategic commissioning plan, and it landed at a particularly challenging time thinking about what we were doing at that time in terms of managing into pressures, operational planning, organisational change, and there was absolute support from board members to take a pragmatic approach to the development of our initial strategic commissioning plan. So what you have in your pack is absolutely in line with that approach. So we submitted this as part of the broader planning pack on the 12th of February. We shared it with our partners as a work in progress draft. We also did the work to think about how we would develop the plan in a way that it is a kind of an initial transition plan. So I think it's probably helpful to say that it's set in terms of the challenging environment that we're working in. So it acknowledges the fact that we need to take a different, more radical approach. It starts to identify some of the opportunities that we have and to outline some of the emerging plans that we have in terms of how we'll enable the shift in the National 10-Year Health Plan in South Yorkshire and how we'll start to enable service transformation at scale. It also talks about the importance of enablers. So it's got in there some of the kind of mechanisms that we'll be looking to use as we move into becoming a strategic commission focused organisation. And it's absolutely an initial plan. So it builds on all the work today. We'll need to develop it further. It confirms the commitment we have to continue to work with our partners. So as we develop it, it will need to be informed by things like the developing neighbourhood health plans. It will need to be aligned into things like our integrated trust delivery plans. It has been developed at that kind of point of thinking about how we move into the new NHS operating model and also how we work within the kind of new and increasing financial challenges that we have. So it aligns to the medium-term finance plan that we've submitted, but there's absolutely more work to do in that space. I think lastly, I think what it does is it starts to set us up for thinking about how we need to pick up our strategic planning at pace going forward. So what we're looking for from the board really is to kind of consider and support the approach that we've taken in terms of the pragmatic approach to the strategic plan and the support for ongoing work in terms of the next steps to develop our strategic approach in line with some of what Emma had described around enabling the 3 shifts and transformation at scale.
Thank you very much. Any questions? We did go through this in December, if I remember rightly. So, Kevin.
Yeah, thank
And then Moira.
And again, just to reiterate, we've had the opportunity in the development session to contribute to this, and I, for one, recognise the common sense approach in this transitional phase. I think you both mentioned radical changes going forward, and I think one thing that we might invest time in working with our partners is creating what the radical change vision is going forward. From the current models in health and the broader services to the newer models. What's the process for Everyone's busy. Our partners are struggling as we are with managing the financial expectations of the system. And therefore, to some extent, we've all got our nose to the wheel, haven't we? How do we create the space with our partners to find a vision going forward that actually everyone can lean into as the basis for that radical change? So what they accept this, next steps really, and timescales.
So we've had some conversations through our SLE, Senior Leadership Executive Group, about this. We've done some work on priorities, but I think what we've got to recognise is our role as a strategic commissioner will be very different in terms of, you know, what we can do and what they can do. And I think the problem is we're transitioning at the same time we're asking providers to pick up more. The idea would be that we're going to pick 5 or 6 big transformation programmes, for example, outpatients. But when I say outpatients, not like we've done it in the last 10 years, actually describe how we're going to get from A to B. So what are the areas we think will have the biggest impact in terms of efficiency? And we need to agree those as a system, because as a strategic commissioner, we can be a pair of service. I think there are things that we can do around cash out, and there are things that, you know, the technical efficiency and the alpha efficiency. So we need to be describing what things can we do as cash out and what things are going to be alpha efficiency. I like the outpatient redesign. We've got to focus on a number of key streams. We can't do everything, and that's what we get into in NHS planning commissioning, is trying to do everything, and we can't. So I think, how do we agree that strategic framework, and how do we get providers to lean in, and how do we help them, bearing in mind that we're just, you know, from the 1st of July, we're going to be a very small, different organisation that will have to think about how we engage and how we enact. But I think that's the process. You know, so we know we've got no more money going over the hill. And we know that transformation takes time, and sometimes integration can cost more money. But we've got to have that, you know, that bottom line in terms of how we're managing the money. So they're the sort of discussions we've had in the Senior Leadership Executive. Chris tabled something at the last one about how that might change, and that was kind of well received by, I think, Provider Chief Executive Mark's on that call, but it seemed to be quite well received. So
Thank you, thank you, Chair.
Laura.
Thank you, Chair. I mean, mine follows on a little bit from what Kevin has alluded to already. It's really the extent to which, as strategic commissioners, we're going to be working with our other partners, particularly public sector partners, in terms of integrated commissioning, where there are opportunities to work together, how we're going to try and align the strategic commissioning intentions of the NHS alongside, for example, the local authority, but there are other partners as well, and the role of health and wellbeing boards in actually bringing people together to make these significant radical changes that we need to make.
So we'll still have the 4 place partnerships, although they won't be in the same format. So again, they will have a role in ensuring that our plans are aligned. We're all, as you know, obviously you sit on the Sheffield Place Board, we're all looking at neighbourhood health and what we can do differently. So again, as part of our transition, we will be describing how those place partnerships work in the new world and how we connect them together, I think, as Chris alluded to in his Chief Executive report.
I mean, I think what we're picking up here is I think everyone's fine with the approach. It's how do we move from an approach to making the change happen? An environment where our growth is towards being, I think, for about 30 or 40 years. And that's really crude, but actually that's the challenge. The challenge, even before we get into the new way of working in July, is to start and keep moving on that approach. And the other thing I'll just add is we talk about working with our providers, which we actually have to work with our trusts. This is going to be really challenging. It's not going to be, we are going to have to drive that kind of change through. Even a simple one you've mentioned, to require the kind of efficiency that we require in outpatients is a massive change in those trusts.
Because I think we have to have some very strict criteria around what we're paying for and what we can't pay for. And I think, again, we need to help trusts and clinicians, you know, do that, because we've got to, you know, when we've got huge variation between specialties and between demand, we've got to be saying, why is that? You know, why is that happening? And actually, as a commission, we can't pay for that anymore. So again, it's about, you know, having some quite sharp elbows, but I think that's the only way we're going to drive this change. And we need to make those savings without a shadow of a doubt. We can't just keep doing more of the same. And it can't just be about new business cases. It's got to be actually what we're doing with the money we've got. Is it making a difference to the patient outcomes?
Shahida.
Yeah, I totally accept that. I think part of that is also how then, as you say, in some aspects, integration costs more money. But I'm just also thinking if we're shifting from hospital to communities to neighbourhoods, how are we then sort of investing in building, say, for example, the BCSE sector? Because quite often they become the critical, linchpin in quite a lot of this stuff. But it just worries me a little bit that as we talk about these big changes, we're focused on trust provided, the sort of institutions, but actually there are other critical infrastructure across the system. What's our sort of direction flow? Because it's one thing to do the change, it's another thing to do the implementation, but it's also about taking everybody on the journey.
So again, I mean, the BCSE are a key part of our place partnerships going forward. They're not, they're still very much, and certainly Sheffield, I think for all of us, they're a key partner. But I think what we've got to look at is where do we spend our money? Where does our money go? If we don't look at those big areas, I mean, we brought things around, commissioning, IVF and things like that. They're not, they're hugely important things, but they're not delivering the efficiencies we need to make. So it's not about ignoring any partner. It's about, I want it to be, because actually the shift to neighbourhood is very much around, how do we work with the non-medical social elements? But actually we are the payer of NHS services, and therefore we need to focus on those efficiencies, I think. So I certainly in Sheffield, I know it's the same in the other 3 places, the BCSE will be a key role. Keep that momentum going as we have done over the last few years. So it's not about ignoring any part, it's just about saying, if we've only got so much capacity as a system, where do we put that to try and, otherwise we're not going to get where we need to be. And I think that's what we've all got to lean into that.
Really helpful. I think people are happy, but it's direction of travel. The really critical issue for me is what does it look like over the next 3 months in terms of an action plan to start to deliver that change that begins to impact on the following year's commissioning cycle. That makes a difference. Emma, Marianne, thank you very much. David, external evaluation of virtual wards. David, welcome.
Yep, so supported by Enrollment today. The purpose of the paper is to provide an update on the evaluation of virtual wards, also known as Hospital at Home, and the continued development is on way. We previously have received a number of updates through presentations I've undertaken for our place reports, and we also report in our IPR. I mean, virtual wards continue to be a tool in our armoury, and we oversee this at the UEC Alliance Board, which I chair. So Dave's going to take us through some of the key elements of the evaluation, and then I'll just pick up the summary of that statement.
Thank you. So South Yorkshire currently has 264 virtual ward beds, which are delivered by 5 NHS providers covering adults and children. Those services are delivered across a range of specialties. All of those providers are live with technology-enabled virtual wards where it's appropriate. We've worked with academics from the University of Sheffield to evaluate adult virtual wards in respiratory and frailty. This has been extremely complex due to models that continue to adapt and evolve. The work streams on admissions and cost have not yet concluded, so they're not reported as part of the update. The analysis does focus on the characteristics of patients on a virtual ward, and there is evidence that acutely unwell patients are being treated outside of a hospital bed setting, therefore avoiding admissions. There's also evidence of reducing length of stay. The quality of evaluation presented indicates 6 key themes have emerged from the analysis of South Yorkshire's virtual ward models, and this provides some insights on the key features of virtual wards that support effective operation. These themes would also have broader applicability to programmes of work that move activity from hospital to the community. The qualitative aspect of the evaluation also notes that healthcare professionals perceive virtual wards as contributing positively to care, and those benefits include patients being in their own home or usual place of residence. We noted that the parallels between the 6 key themes presented from the university and the National NHS England Virtual Ward Operational Framework, that's a quality improvement tool we've been using to inform the development of our virtual ward models. There's 10 core components that are identified in that model that identify and maximise the benefits of patients and the wider system. That framework supports a consistency in approach and models whilst allowing services to be tailored to local place models. That provides local operational flexibility within some prescribed elements. The scope of the evaluation covers activity up to the end of March 2024. In the subsequent period, virtual wards have continued to develop as described by that operational framework. The South Yorkshire providers are therefore participating in the national evaluation of mature adult virtual wards that was commissioned by NHS England in July 2025. It's a large-scale 2-year evaluation and planned to report in 2027, which will enhance the evidence base on optimal virtual models. So the findings, alongside local reviews, place and provider level evaluations, are being used to support our recommendation for the continued development and expansion of virtual wards, to be used as a tool to prevent avoidable admissions in hospital, step up, or support early discharge out of hospital, step down. We know that this needs to be tailored to the communities that we serve, build on the place models and arrangements. So the ask of board is to note the report and the recommendation above. Thank you.
David, thank you. Any questions, Chris?
Yeah, thanks, David. It's great that's on our agenda today because it is undoubtedly, and I love that. I much prefer the language of hospital at home to virtual ward, and that's something over Rotherham Partnership very much tending to use as well, isn't it? I think we're probably underselling this, to be honest. Is that when I think about the hospice movement, and I think that so Rotherham Hospice has a caseload of hospice at home of about 500 at any point in time. I'm sure it's the same in the other hospices in South Yorkshire. And perhaps the hospice movement had led the way on this before we started using the hospital at home language. So I do wonder whether we might be underselling this and we've got learning potentially from other sectors that we could pick up. So just a suggestion, Dave, but just thank you for bringing them forward.
I think there is something in that, because the question I asked when I read this, it's fascinating stuff, is what's the scope, how much more could we do with this? And economically, what does that look like? How many admissions, or how many beds, because you can do both on admission and discharge, as you rightly say, David, could we, how many more people could we support? Because qualitatively, if I was a patient, this feels a much better service. I do not want to be in hospital, no offence. And if we can support far more, what does that look like? What does an acute hospital look like if we really went this at scale? And that's the stuff that I think it still feels, I mean, and I don't even know whether 264 beds for 1.4 million population is high or low. If that would interest me as well. So there's something that says, have we got more scope? And what would it look like? And there's something in there that the next stage should be trying to get into that conversation. Because this feels really helpful stuff. Sarah,
Mark's on the.
Oh, sorry, Mark as well. Come back to you, Mark. Sorry.
Just in
Sarah.
terms of your comment, because this has to feature strongly in neighbourhood health, isn't it? If it's going to grow, it's going to have to be that neighbourhood wraparound to keeping people out of hospital. I worry that we count things differently. So I'm a bit at glass half empty with Chris in terms of this and whether we've developed unmet need. But absolutely, until we get that into the neighbourhood, wrap them around and actually keep people out of hospital, it has to be part of that.
Yeah, good. Mark, sorry I missed you. I apologise, Mark.
No problem. I just thought as a provider of these services might be helpful just to give our perspective. And what I would say is the report is very, very consistent with our own findings and our understanding. So it really does reflect what we think is happening on the ground. Just a couple of points I probably would, I think, are worth emphasising, they're including the report as well. One of which is, I mean, I spent a day with a neighbourhood nurse not long ago, and there is still a lot of, I guess, digital inequity in all of our populations, and some people are not confident at all about using any form of digital device to support them. So you know, we were with one family, we just wanted to come here and see us. They weren't interested in this type of approach. So we still have to consider how we can support people to do this where appropriate. I think we can absolutely demonstrate for the number of people that we have on our virtual ward caseload that we are preventing hospital admissions. If I speak to Richard at the hospital, he probably doesn't see that in net numbers, which probably means there's other reasons for people going to hospital as well that virtual wards are tackling. But we absolutely do know that we've stopped people from going into hospital. And I think what we just need to be aware of is that there's still a challenge on capacity, because irrespective, depending what the condition is of the person that we're looking after on a virtual ward, they are still going to need medical input, and that is, I guess, a finite resource as well. But as I say, overall, I think it's a really good report, and it's very consistent with our own conclusions.
That's really helpful. Kevin.
Thanks, Chair. There's a sort of a naive, inevitable question in this, and obviously we've got the recommendation that we need to, the recommendation to expand, and that feels right. And of course, there is a broader context of our overall bed stock in hospitals. But the naive question is, where will we expand, and where is Sheffield in particular? Because just looking at the raw numbers, of course, it implies, it may not be true, that there's more to be done in Sheffield than in other areas. But these are numbers out of the context, aren't they? So just what's our thinking about next steps across all our places?
Yes, so in places such as Doncaster and Rotherham, we've described it as multi-specialty reports because we've got a single virtual ward that's enabled to onboard patients from a broad range of specialties. I think in Doncaster it's 10 specialties, in Rotherham it's about 5 different pathways, and they use the beds flexibly as part of the larger model. I think the variance in Sheffield is due to existing services that meet that patient need. So they're showing there's additional capacity actually created through this funding, but they do have pathways for respiratory patients and nurses in the community visiting patients. So the table is a reflection of how the original funding has been used to do something different rather than the encompass of all services.
And just to come in on that, Kevin, as an old acute provider, there is a counted game you can play with virtual wards, and children haven't played that game, which I think is fair play to them, the services as they are.
So there is something for me, Chairman, about being careful when we publish the raw numbers.
Yeah.
But just actually, what did the state of play about our virtual capacity, given the potential for game playing in the numbers? But where's the real opportunity, and how best do we describe it beyond these raw numbers? Then, 'cause these are potentially in their own quite misleading.
Yeah, that's fine. That's fair. Katie and then Dave. Katie.
So I think it's a great report, and I think it's good to see the outputs. I think one of the things we're certainly talking about in Barnsley, and obviously Mark and Dawn in Swift are sort of leading some of this work, is where do we take it next? And we've got a really interesting discussion as an ICB going with a company called Social Fund linked to the Alzheimer's Society about dementia, and starting to think through how we try and re-engineer our entire pathway around dementia, probably focusing on post-diagnosis. One of the key things that we've gotten into talking about with clinicians about that is some of those medical conditions that might mean a person with dementia ends up in an emergency department situation. So there's some appetite to think about some of that. I think the tricky bit, which everyone's alluded to, is what's the business case for it? Because actually, as you start to look at it, you can see there's a massive patient benefit. But actually, part of the social fund discussion is if we invest some money with you in Barnsley or any system to kind of prime this, you then have to create an environment where that money is invested currently. So we're working through currently the business case. In fact, we've got another meeting this afternoon about how do you show either a flow of funds or look at, it's hard to see cashable savings in this, but can you show a flow of funds or a movement of resource out from acute into community? So I'm not sure whether we'll be able to show that, but we are definitely trying to do some thinking to move this into a different spaces.
I've got David Brandon and David.
I guess let's not be lost in that technology in health and care has been used for a long time. Telehealth was involved in a programme about 15 years and it continues to be. So, this came out of COVID and specifically about helping people an alternative to being admitted. That's where this is evolved from. So it is quite niche the way it's reported, because that's what the national programme defined and that's what we were given money for and that's what we had to report on. But when we talk about evolving, the initial model wasn't to include children, wasn't to include oncology. So each speciality has it's more of a sort of concept and a way of working. Is there a way you can do this differently? Can it meet the 10-year health plan? So, it's going to be difficult with the business model. I think, David, if I'm right, wasn't there about 6,500 bed days saved by this model? That's been made a saving. But equally, as Sarah says, you know, is that unmet need? Is that providing a service that people didn't get before? So, you know, when we're in a mindset of trying to get cash release in savings because of the financial climate we're in, that doesn't negate the benefits of the programme, because those people have you know, had a different care option.
I know the risk for the NHS has always been that we start a service with the attempt of reshaping acute care, and the acute care demand seems to still come through the front door. And we've all got examples of services we've been involved in where that's the case. It doesn't mean the service you started wasn't really good and valuable, but sometimes you suck up demand that you didn't know was there, and sometimes there's demand beyond the system that you didn't see and is now coming through the front door. This is really complex stuff. And when we talk about left shift, that's writ large the challenge we've got. David and then Kathy. David.
Yeah, so I think just to illustrate how virtual wards have developed. So when I came to a board development session in June 2024, I think I said there's around 4,500 patients going through a virtual ward each year. In the paper, we've noted that there's approximately 6,300 patients going through a virtual ward each year now. So that's the growth. We know the average of stay of patients, most patients have a stay between 5 and 9 days. So if you think about approximately 250 patients going on a virtual ward every fortnight with a length of stay around 5 to 9 days, that in the region of 30,000 plus bed days a year. So it's absolutely huge in terms of the amount of bed days for patients. I just wanted to kind of make a bit of a statement around the technology. So the NHS England operational framework says that all virtual wards must have the ability to onboard patients using technology, but patients do not have to accept the technology to be onboarded onto a virtual ward. So we've got a technology provider that onboards patients, works with carers or patients, and provides patients with smartphones or tablets that can be delivered to their home, and provides data where necessary, which goes some way to kind of counter some of the barriers. But you do not have to accept technology to be on this virtual ward.
That's really helpful, Kathy.
Yeah, and I suppose it was just kind of the economic benefit case, because I think we have to be really careful around savings, because actually if we can't physically take beds out of an acute provider and re-engineer that money somewhere else in the system to provide differently, then we're not really making savings. Actually, we continue to add on and layer on. So I do think it kind of links back to Emma's previous paper around kind of strategic commitment intent, and that's where do we use some of that, rather than keep using this analogy of virtual walls, where do we use the learning in relation to what we commission from a service provision in that neighbourhood health space as we go forward.
I think mine's kind of a similar point. We've talked about health on the high street in terms of each of the places. We've talked about strategic commissioning, and we're talking about in terms of the specialities for the hospital at home. We're assuming that the acute alliance and collaborative is going to continue to some extent, but where is that coming together in terms of actually, are we going to do are all the 4 places going to do very different in terms of hospital at home, or actually is there something about understanding what a South Yorkshire perspective might be, and what an economy of scale might look like, and what a learning might look like at that level? Because the risk is that health on the high street, hospital at home, each place goes and does its own thing, but actually that's not really what maybe from a strategic commissioning perspective may be best in terms of outcomes for people and value for money. And I'm not telling hospitals what to do.
No, Shafiq, I think that's the challenge for the ICB and its new strategic commissioning. Yeah. How much of this has to be, ought to be consistent? How much of it? If I go into Barnsley, it's very different than when I go into Doncaster. I don't believe I could use the same solutions, but I'd like to see consistency of service and quality of service. Now, that's the challenge. What does that look like? So my view is I don't think hospital at home, I like that better, by the way, has to be the same in every place, because I think they're very different needs for populations. But if we can't learn the lessons from each place and apply it to the place, we've failed as a strategic commissioner. And I think there's times we've done that. So real challenge there, I think. David?
I think when we set out on this, we thought we were going to have a single model for South Yorkshire. That's what we thought the evaluation would say. That's not the outcome we've come to. What we said is it's too nuanced, and you need clinical buy-in, you need local commissioning arrangements, you need relationships, and therefore you can't have a single model. And actually, some of the needs are different in different communities, so it has to evolve in what's important to those sub places of South Yorkshire.
That might be more marked by the way we move to neighbourhood health. Can we just, that doesn't mean we'll be consistent.
Yeah.
And then
So today, this is really helpful, because I think it takes us to a point of concluding what we probably already knew, that this is a legitimate and positive part of our suite of urgent care capacity. Part of our danger around this board table is looking at it separately. I fell into the trap of saying Sheffield only 20 beds. It's much more complex than that. But without, to pick up your point, Chair, about moving forward, do we need to be setting the parameters for individual places? Because places are different. I think we should be learning from each other in terms of what's the best practice, but really looking at overall urgent care capacity and setting the challenge that they can demonstrate, our providers, our collection of providers, can start to demonstrate best value throughout of this. We're almost now coming at it the wrong lens, aren't we, as a commissioner? So I think it's good to get to a point. I think it's positive, although some of the research was still based upon early findings, but really put it into the armoury of our providers collectively of, what's the solution going forward without setting definitive parameters, apart from demonstrating best value and what's right for patients.
Yeah, I think that's probably right. Moira?
Yeah, I was just going to make a point about the terminology, which I know we've talked a little bit about. I mean, I strongly feel we should be adopting terms like hospital at home rather than virtual wards, because it's much more person focused and actually what we're trying to do, which is actually to provide that level of support for people in their own homes to prevent hospital admissions. And the other thing is from, recognising that the 4 places are different and have got different, you're starting from different baselines. But I think from a strategic commissioning perspective, we ought to be saying, this is what we think what good looks like in relation to hospital at home and alternatives. And then the individual places can measure themselves against some of those sort of good practice models.
Yeah, I think it's reasonable to say we expect the place to have a range of services available to their residents that include the following, okay? But not that we have the perfect picture on how many should be available in each place and what shape. The question down the line would be, how directed do we get in that? It's a question. I've got an answer. That's a question. The answer might be later, quite directed. Emma.
So I think it comes back to, this is about managing frailty. It's not just about virtual walls, it's about frailty. And I think we need to have a broader view of frailty in South Yorkshire. And then we'd say to places, how do you, and I think there's some really good examples, like in West Herts, I think they're doing some really good work around, hospital at home, and there's some really good contracts, there's different payments. So we need to look again across the country to see where these things are happening. But I think we need an approach to frailty, of which this is part of that. But I think that you're right, Kevin, we describe it differently. And frailty is end to end, isn't it? It's not just about this one bit. So what are we doing? What's our approach to frailty across the system?
I think that's probably the right question. David and Mariana, and then I'm going to finish the conversation.
I was just going to say that we've already mentioned it, but there's a natural flow from patients being managed in neighbourhoods and then being escalated up through to kind of different settings under the hospital at home banner to virtual wards. I think I just wanted to reference that virtual wards have very specific admission criteria. Our services are using acuity tools to make sure that the right patient is being onboarded, but that doesn't prevent patients being stepped up from neighbourhoods. And so kind of the line between a patient being managed using very similar technology and in the neighbourhood and a patient being managed in a virtual ward can be quite fine, can't it, as part of that continuum.
Mariana.
Just listening to the kind of contribution of the board members, there's something, isn't there, about as we develop as a strategic commissioner about balance. Because although we have, differences in our places in terms of population and the assets they have, the journey they've been on in terms of the urgent emergency care, virtual wards, neighbourhood models, etc. But actually there is something about what we want to all collectively achieve. through our kind of our hospital developments, you know, the outcomes we want to see. And actually we want to see those outcomes in terms of the contribution to improving health across all of South Yorkshire, don't we? So there is that balance of, well what's the kind of the underpinning principles for our approaches that could be consistent, and what's the outcomes we want to achieve together. And I think there's that balance as a strategic commissioner between, you know, that consistency in approach and that creating that environment that then enables each of our places to continue on their journey to develop the models that best meet the populations they serve.
Accurate. I think striking that balance will be our challenge. So we finish it there. David, really helpful. You saw the interest in that. I think it was really good. Not only in the virtual board structure, but also in what it means for us as a strategic commissioner and our role. And I think that's a real challenge for us going forward. So really helpful. And then we get on to place partnerships, which feels entirely reasonable given the conversation we've had. These are in alphabetical order. Those who think Barnsley goes first becomes best. That's what they would tell me. These are alphabetical with Barnsley. Katie, I'm going to see you.
Thanks very much. So we just highlighted some of the key areas as ever that we're involved in. So we're absolutely delighted in Barnsley that we have been named the first tech town for AI Trailblazer. That comes with some additional investment and obviously some really good opportunities for links both across South Yorkshire, but also into universities and other digital companies. We've been on this journey quite a long time. The hospital is well into digitising its kind of internal processes, which is really helpful. And we're also in a great position, and our LinkedIn is an ICB to this, through some of the work we've been doing around the shared care record. So all the work that's been done under David's with officers around bringing all of the data for like adult social care, our hospice, the hospital, primary care together. We're trying to also bed into this as we move forward. So really delighted that that is in place. Colleagues may be aware, and obviously this will apply to other bits of South Yorkshire as well, that we had an original plan around the provision of alternative provision for SEND in Barnsley, which was paused over a good number of months ago as the government worked through its new SEND policy. What we've that has now been restarted, but what we've decided as a local authority with our partners is that rather than push this through a government-led programme, we're going to take the management of this in-house into the council so that we will work with two partners at a much quicker pace than the national programme would be enable us to create some alternative provision places within Barnsley for our children moving forward. And again, that feels really consistent with trying to ensure that our SEND provision is as good as it possibly can be. At the moment, we've got a range of different provision in place, but this will enable us to really capture the growth element that we know we are going to kind of having come over the top hill. Currently, and I'm not saying this with any, I am really proud of it, we are one of the most productive councils in the country. We were delighted to be named in an Empower Index in the Municipal Journal for this, and it really does, I think, reinforce the work that we're trying to do around ensuring that we've got really strong outcomes focus and challenge with our teams to make sure that we keep doing the activity around financial constraints. And then, you know, no Barnsley briefing. I know we've already talked about Health on the High Street, but no Barnsley briefing would be complete without another mention of Health on the High Street and visit from Wes Streeting to open the Alambrad patients. It was a really positive visit. I think patients were a little bemused because we carried on doing services as the visit was going on, but really, really positive. And it was great to hear the Health Secretary talking about this and other examples of this as being the future of the NHS. So it was a really, really positive visit, and we did ask him about more resources. We haven't got anywhere yet, but we did.
It wouldn't be a Barnsley visit unless that was achieved.
So, and then just picking up on some of the other great work that's going along across the partnership, of which we are part of the ICB. So some brilliant work in Swift around a mental health crisis research project, which we really hope will begin to impact on the design that we've got around some of our services. And the work is supported by the National Institute for Health and Care Research. So really excited about that. Some great physical health and mental health work going on around our new walking initiative, which is being offered through our both our sport and physical health team within the council and Barnsley Premier Leisure. So a lot of work going on around that. And then just an update on our SEND inspection. So that happened maybe 3 or 4 weeks ago at the moment. The local area partnership is still awaiting the outcome of the final report and formal feedback. But I think from an ICB perspective, we were absolutely able to evidence the work that's been happening in SEND from the ICB and from a health perspective. Obviously, there were some interviews with lots of our staff and staff in Mark's bit of the world and also in the acute trust. And I think overall, we were able to show really cohesive partnership working and support for children with SEND needs. And then final thing just to mention is around the work that we're doing on trying to improve cancer screening uptake. This continues our focus on really trying to improve our position as the worst performer for healthy life expectancy in South Yorkshire. So really trying to encourage people to come into general practice and increase screening in cervical, breast and bowel.
Thanks, Pete. Can I just, something that occurred to me when you said it, clearly there's big changes going on around SEND. We've all heard about, actually, it might be helpful at some point, it might be a budget formal or to say about, I must confess I don't understand what those changes are. There's part of me that says maybe I should. So can we just, I don't know how you, I don't mind how you brief us, but I think there is something that says, let you know the changes that are coming your way, if you don't mind. Kathy?
Yeah, I wonder if it's worth Katie and I bring something collectively. They've got a local authority lens and a health lens. So we've had a briefing through the NHSE route, and I think there's a workshop the week after next. So actually bringing something collectively, because I think that there'll probably be, we
all find it helpful. It's really a massive area of demand. We're at huge financial pressures. I just think it'd be helpful to say, let's tell you what's going on, even if it only does that. Personally, as chair, I find that helpful. Katie, thank you. Doncaster.
Thank you, Chair. Good morning, everybody. Today I wanted to concentrate both the Doncaster and Place reports on, firstly, an update on the usual fantastic work that's going on, but secondly, emphasising the work that I really feel needs protecting under the new model arrangements with partners. A lot of that's been mentioned throughout the meeting already, really, but whether it's neighbourhood health development, citizen and resident engagement, and indeed the vast and valuable work that we do with our voluntary community and faith sector really is at the heart of the 10-year plan, and I feel at the heart of our strategy going forward. I feel we need to ensure that as we move to a strategic commissioning body, and definitely working within difficult financial climes, that this work is maintained and accelerated. I recognise actually what we discussed during the strategic commissioning section, that we can't do everything, but I feel we lose this type of work at our peril. That's my sermon over. I'll start with Doncaster. I'm going to cover the National Neighbourhood Health Visit that we had last month to both Doncaster and Rotherham by Dr. Manil Bakai. Dr. Bakai is a GP in London, and she's the national lead of the programme. And as we all know, Doncaster and Rotherham are part of the 43 pilot sites for the national programme. We wanted to take the opportunity really to bend her ear in terms of how neighbourhood health needs elements of clarity nationally. I do think there is a danger that the banner of neighbourhood health is all things to all people at the moment, so there's definitely some clarification around that. But we wanted to take the opportunity to take it to the front line and see many examples of where neighbourhood health is already in operation. It's just that we're calling it something different at the moment. So in Doncaster, it was a great opportunity to showcase the fantastic work that the voluntary community sector are doing to support residents and strengthen our communities. We had presentations and visits from Citizens Advice Doncaster, showing the real impact that advice and prescription is having. We've had presentations on to that effect here at the board. And Minal visited the team at So Mindful Crafts in Edlington. If anybody's wondering, those pictures, that is a knitted esophagus, which is used to promote one of the cancer screening campaigns that the work is being done in Edlington. They are available on request if anybody wants one.
I never thought that needed.
But it's something you didn't know you wanted to leave. Sorry. We also outline the work that we've begun with our partners and neighbourhood teams across Doncaster. Our approach in Doncaster is intentionally different. We're prototyping at village level, staying rooted in the community, centred on co-design and shaping the work that is unique to each neighbourhood, so that we can understand what matters locally to our residents. And we're enabling those teams to work in a relational and liberated way. It is worth saying that nationally, we are awaiting much more guidance on neighbourhood health, including the contractual mechanisms. Everything tells me that that's delayed into the summer, including the proposed financial shifts to enable neighbourhood health. The message from Manal was don't wait, get on and try things within the neighbourhoods, whilst working on further strengthening the partnership arrangements that the ICB can contract with in the future. So let's get on with it and see what. I think if anything, it'll be a catch up nationally to the work that we're doing. The second 2 pages of the report, Chair, describe the various ways our partners are providing examples of best practice and support to residents that, as I say, we must fight to protect. Club Doncaster have been recognised nationally for the postnatal support and the best practice there. Really proud of that work. Get Doncaster Moving have continued to be recognised nationally and received national funding for the work such as Dance On. I haven't been part of that yet, but it is to combat our inactivity across the city, which our Health and Wellbeing Board have recognised as a key priority, and the success rates are very encouraging at the moment. Mental health and social isolation is another area of key focus for Doncaster. 27% of people in Doncaster feel they do not have as much social interaction as they wish. We have a new leadership across our Doncaster GP Federation at the moment, and they're leading some work with Doncaster Mind on time to talk and a number of pop-up sessions across the city centre. And then finally, on the city centre, there has been some very encouraging news in terms of receipt of national capital funding for our Waterdale City Centre Health and Care Hub. We now feel we can accelerate the development of our children and young people's mental health offer in the city centre and our outpatient offer over the next year. As members, I mean, we've talked about health on the high street already. As members know, this is starting the work to unlock the city centre development, taking advantage of increased footfall to also encourage retail, leisure and housing back into the city centre, as we've already heard brilliantly from Katie early on. It works. And it's great that, see, after a long push in Doncaster, I think we're really starting to make some progress. I'll pause there on any Doncaster update.
Any questions? Johnny? Rotherham.
So, Rotherham, again, so I'll just touch on the national visit. And I met with members of the Doncaster Place Board to hear more about the shared vision for neighbourhood health, and then visited the Broom Lane Medical Centre, where observed a proactive multidisciplinary team in action. Multidisciplinary team working is at the heart of neighbourhood health, and she was very impressed with how those multi-organisational professionals work together. The key focus of the visit was to explore models that strengthen links with the voluntary community and social enterprise sector. To highlight this, Manal visited UAS Responded Services, a valued social prescribing partner, and that's based at Clifton Park. The feedback to the Rotherham team was extremely positive. She praised the strength of the partnership working across Rotherham and highlighted how impressed she was with both the local approaches to the pilot, but also the longer term vision for neighbourhood health. The Rotherham team have produced a brochure on what neighbourhood health is and how the future will look differently. I'd like to share that with the board if people have been interested, as it does a good job of capturing everything as we know it that neighbourhood health will look like in the future. The Place Board welcomed a presentation from Health Watch Rotherham. I'll talk about this, but the Chief Executive may wish to add more. The presentation outlined Health Watchers reach between, that should be April 25 to December 25. Thank you. And it just shows really the sheer volume of the work that Health Watch does across the town, the reach that it has. It goes without saying we can't lose the engagement of our residents across South Yorkshire. Obviously, we're looking at our model internally in terms of engagement going forward in the new world, but relations with partners such as Health Watch, whose own future is somewhat, you know, up in the air, is going to have to be looked at across the system. Finally, there is a slide that is an infographic of the Better Mental Health for All partnership approach across Rotherham. And as I've observed in my stewardship of Rotherham, it's a truly multi-organisational commitment. An example of that for Pet Love in the Room is the hospice have introduced Pause for Peace. It's a unique service for patients, cats and dogs, supporting the timely admission of patients by providing on-site compassionate care for their pets, whilst ensuring they are not separated from their companions. It's recognised as a UK first initiative in this area, more holistic approach to care. My final observation of the Rotherham Place this month is there are very positive and tangible moves amongst partners to move to the new world of partnership arrangements. Some of those are in this room, and that includes a proper understanding of the transformational capacity required to keep the drive of this work going forward. These people might not be employed by the ICB, but they're absolutely needed in the system, and I see a move in Rotherham across organisations to employ that expertise going forward.
Thank you very much. On Health Watch, again, that might be something that I'd like an update, doesn't have to be now, on where we are. We saw the announcement several months ago.
Yeah, the health bill is due in Parliament on the 15th of April.
Right.
Given what's happening now in the world has changed since they announced that last week. That may change, but yeah, that's how it's expected to go. So again, I'd echo what Anthony said about looking at what you're going to commission and how that voice looks. There's a great case for VCS to be involved, but that's not what patient voice is about independently. Gaining those lived experienced voices, they're not always connected to a community group, and it's really important that we remember that. And that's what Health Watch does primarily, seek those voices out. Giving the information to the public as well. We do the Let's Talk events that gives the public information about health topics of their choosing, using the experts that we have in the room. So yeah, again, I'd echo that, but it's still all very much up in the air.
And I saw a really interesting article from a Labour health lord who I knew years ago, who used to run the NHS Confederation, who said if there's one thing we're going to change in the Lords, it is actually getting rid of health watch. I think there's some way to go. Is I think what this looks like. Maybe it's just so that we can keep abreast of as a board.
Yeah, I think there needs to be a contingency if Health Watch remains. And yeah.
Kim, thank you. Emma, can you pick up Sheffield for us?
Thank you, Chair. Yeah, so the first update is just on the North East Model Visitors Programme. So that this is us continues to improve the health and happiness of diverse communities in the North East of the city. We funded over 50 voluntary and community sector organisations to deliver lots of different things. And I think, again, just supporting what Anthony has said, you know, we've invested in this programme over the last couple of years, and hopefully we'll be able to maintain that investment. We've actually got New Local coming today. New Local are an independent think tank who are helping us do some of the evaluation, what's the return on investment? Because again, I think it's really important that we're able to demonstrate that actually some of this work is so far upstream, but the impact that it has on people's lives is huge, but it's really hard to measure. So again, how do we use that evaluation across South Yorkshire? Again, you know, as we're moving into commissioning, strategic commissioning organisation, how do we look at the work that's going on in the 4 places and really start to get that value and drive that value and really sort of, I think, some of that work, because I do worry, as you say, Shahida, that some of that might be, you know, overshadowed by the issues we're under financially. So obviously there are some quotes there, you know, which I won't read, but I think the one about I've had more help through this allotment than from anywhere else. Thank God, and you for Thursdays and the allotment days. So to me, these things are so important in terms of the isolation. And as I say, some people aren't anywhere near a health service, but actually, you know, we're supporting people to get there. So I think this stuff is hugely important moving forward. The primary care estate update, again, you might have seen some of this. So we have that capital investment, and you might see that we've got Foundry One on Spittal Hill, Spittal Road, you might see that already, it's nearly built. It's a fantastic facility, and again, it's really great to see something, as I came into this organisation, to see something now in bricks and mortar there. We've got the city centre one, which is the old bank, legal discussions are ongoing around that, and SAP 2, the final negotiations are underway with the contractor, again, so really great premises. We've also, not just alongside that, we've also been investing in other premises across Sheffield with additional 24 clinic rooms in 5 practices, with a further 8 to be completed. So again, you know, I think as an ICB, one of the things we have done is invest in primary care estates because we have that funding. So again, really great that we've been able to do that as an organisation. The Gledless and Heathley 24/7 mental health pilot, again, huge exemplar. Not all the exemplars are in Barnsley, Katie. I have to say that. But again, you know, that is coming on stream. We're looking potentially at another development as well, another opportunity. So again, some brilliant work going on, and again, a really good example of neighbourhood health and how we can bring things out of traditional environments into communities and really create a different offer, which is what we need to do more of. So again, that's going on well. And I think one thing I wanted to touch on was about managing ADHD diagnosis. So I hate the word pilot, but it's obviously here, the Sheffield University GP pilot. So like the rest of the country, we've had a high number of people waiting for ADHD and autism assessments. Across South Yorkshire, we've got 30,000 people on NHS waiting lists, as you know, and we're spending lots of money on Right to Choose, which again is on the agenda today. So the national policy is not keeping up with the issues. Common view of overdiagnosis. But I think we've been quite unique that we've got 2 universities, and that's where we're seeing the biggest demand profile. So through a place-led commissioning work, we've developed a new pilot. It's introduced a triage screening assessment service through Primary Care Sheffield with the Sheffield University Health Services GP practice, and it's aimed at reviewing and supporting patients before offering them a choice of secondary care if appropriate. So the offer includes diagnosis by a GP with a specialism in ADHD for less complex cases, obviously clinically appropriate for primary care. So the initial impact from the first 3 months is prior to clinical screening, the needs-led approach has led up to a 75% reduction in secondary care referrals for diagnosis. Following clinical screening, 30% are suitable for GP assessment and 54% are referred to secondary care, 16% screened out. So again, it's small numbers, but actually it's going in the right direction, and it shows that actually if you start to do things differently, you make a huge difference in demand. So again, we're feeding this work up through our local MPs actually into some of that ADHD task force work, and hopefully, you know, we'll be able to expand that across the city and actually in other places if it's proved more successful. There's a bit on our winter surge plan. Again, just one thing to pick out that our wait for 45, obviously the handover time for ambulance services, we maintain that throughout the winter in Sheffield, and I think, you know, that's brilliant in terms of people not being on the back of ambulances and actually getting transferring to ED appropriately. And there's just another bit at the end around the generation study, and again, I think about genomics and the role they're going to have in the future in terms of how we start to think about how we deploy our resource, what genomics tell us, how we use data to inform our strategic commissioning work. I think, again, this is a really useful study which will help us start to plan, think differently about those kind of services. So that's all I wanted to say. Thank you, Chair.
Emma, thank you. Any question?
Yeah, I forgot to mention about Emma's primary care slide reminded me that the work that we've done across South Yorkshire in terms of primary care capital has been nominated for a Health Service Journal Partnership Award, which is this month, and I think that's credit to all the teams for the work that's been done in particularly in Sheffield and Doncaster. I would say that, you know, this is one area where we're ahead of the game at Barnsley, except Barnsley have been nominated in the same category for their work on health on the high street. So big competition on the
just for background on that. So what happened is in 2019, only 2 areas in the country were awarded capital investment. We got 50 million, Norfolk Wade, we got 20 million. So if anyone else in the country were to win that award, they've done really well and deserve it. So yeah, it is fun. We should celebrate and certainly into communication because the buildings are coming up. we've got the one in Rotherham, Waverley, which opens shortly as well. There's the Sheffield ones there as highlighted in Doncaster as well. So it's a case of, really celebrating those come to fruition, because there's a lot of hard yards. A lot of people have worked a lot of hard yards to get this. Not easy putting those buildings up. I think one in Sheffield involved like 10 GP practices, didn't it? So you can imagine, getting that to work. So praise to everyone involved.
Okay. Sorry, do you want to say something?
Yeah, just really quickly. I think I was at the visit with Minal Bahai when she came to Rotherham, but it's just a reflection on all of our sectors. When we're talking about sort of innovation, transformation, the kind of stuff that's happening in each of our areas, the North East project in Sheffield, the national 2 neighbourhood projects, Doncaster and Rotherham from national. I think one of the things that we've got going for us here in South Yorkshire is we push the boundaries on innovation. We will test things out, we will try things. I mean, yes, we got Rotherham and Doncaster, but it was the work in Sheffield North East that informed the national neighbourhoods task force and strategy and policy around that. But I think one of the things that we're not very good at, and Chris will tell you, I always say this in Rotherham, is about really shouting about what we do here at a local level. And I think that's more elevated at a regional level. I think we've got massive opportunities. And yes, it's really difficult financial circumstances, but I think there is something about having a collective conversation around intentional strategic commissioning. So it's not just about doing it differently. We are all, in some cases, already doing it differently and have the ability to demonstrate that. What we're not then doing is kind of then pushing that into a collective conversation about, well, where's the shared learning in this? Everybody in South Yorkshire doesn't have to do it the same, but there's something about consistency and saying, okay, well, we've tried all these different things. Can we save a bit of resource and time by sharing that information and knowledge? So I think for me, there's just something about how do we take the best of what's happening in each of our 4 places, but find a way to kind of have a collective reflection back at national as well, because we are, interestingly enough, impacting policy individually, but not collectively.
So, thank you for the report. I'll take a break now. We will start again at 10 past by that clock. Item 13, performance objectives. Sarah, are you leading us through this?
Yes, thank you.
Right.
So just before we get into the detail, I thought it would be helpful if I gave a bit of a briefing from a Jim Mackey meeting earlier this week where the NHS is potentially going to end at the end of March, and then just talk about what the next steps are for developing this and how ICBs are going to be judged. And then I'll go into the detail. So in terms of the NHS, we had a briefing from Jim Mackey on Monday. They are quite confident that we will balance the money across the system, which will be a huge, they were very, very vocal in terms of the fact that they would balance the money. The expectation is that the RTT, so 65% of patients getting treated within 18 weeks, is extremely tight, and the ask was for all providers to keep pushing in the way they are through Q4, but the expectation was that they would get there in terms of RTT or there and thereabouts. In terms of UEC and the 4-hour standards, that's been missed nationally. So they do not expect to deliver that standard, even though there are incentives to do that in March, and I'll come on to that. And what we did all celebrate, though, and we've already touched on it, was the ambulance waits. Nationally, and certainly South Yorkshire, we've put massive effort into delivering the ambulance waits. So that was kind of the messages. The other message was that everybody submitted balanced plans, and well, how good are we? In terms of how much closer are we this year in terms of submitting balanced plans, clearly everybody recognised the risk associated with that, and we'll pick that up later down the agenda. So really positive messages in terms of money and RTT. In terms of this report going forward, clearly this is March and some of the data is January. We will transition over the next few months into what the ICB is accountable for delivery in terms of the operating standards. The health warning I will put into this is though we still don't yet know what the NOH indicators are going to be for ICBs. So that will transition over the summer, and we're expecting, hopefully we'll get them this month. But that's the national plan, but we've yet to see them, and then we'll see what indicators we're judged against. So this report will transition as we move forward. In terms of the report that you've got in the pack, there isn't really any surprises in there. It's pretty consistent with what you've seen in previous months. In terms of ED for January, and that's the 4-hour standards, across South Yorkshire, we delivered 68% against a plan of 73%. So all providers were off plan. I think that, well, that's the case. And I think that has to be seen in the context of winter, where we did manage winter in terms of escalation levels and patient safety. We did have a safe winter. There is now, though, a national reset or a spring reset in urgent care, where trusts are being encouraged to strive for the March 78% target. That's been led by capital incentives, but it's not cash backed, so not all providers would benefit even if they did hit the target. So everybody's been encouraged. To be fair, we have come out of winter, we have seen an improvement in our performance, and we need to do that anyway in terms of getting back on track in terms of UEC. In terms of cancer, which has been a concern for the group, in terms of our FDS, i.e. patients being notified of whether they do or don't have cancer within 28 days, we're back on track for that target, and we're hitting the 80% of patients. The target that we've struggled with is our cancer in patients being treated within 62 days. For December, South Yorkshire delivered 63.4% of patients treated within 62 days. That's against a plan of 70%. And last year's performance was 70% as well. So we are 7% down on where we were at this time last year. That's clearly driven by, well, the majority of that is driven by STH, and we are seeing a reduction in the STH backlog, and we are seeing small improvement months on months with that, and we'll continue to track that. All of our other DGHs did have what I would describe as a performance wobble earlier in the year, but all of them are on an upward trajectory now and are delivering and intend to deliver the standards in terms of their revised trajectory. So quite a lot of effort gone into that. National directive to use the cancer monies to make sure that performance was supported in the last quarter, and we've done that. We've helped out with endoscopy-laced additional breast clinics, stuff to try and get ourselves back on track in terms of cancer. So that work continues. In terms of elective, and as I say, this is a huge health warning because STH is still not in the national numbers, but from again, given we've got sprint monies at Q4, we've had a lot of national monies in our other DGHs. We are seeing improvement where we started the year above 65% patients treated. We dipped in the summer and we were sitting at 63 for quite some time. We are now in the last couple of weeks starting to see improvements on the back of the outpatient sprints. So that's really, really positive in terms of that target. And we're over the 65% last week. So there's still a few weeks to go, and there is quite a bit of activity in that space. So that's positive news. In terms of mental health, the data's there. You continue to see that reduction in out of area placements, and in GP and GP attends, we continue to exceed our trajectory in the number of appointments that we have in that space. So happy to stop there. As I say, most of it has been, I would hope none of it was a shock, and there is no big variations on where we were at the previous board.
Thank you. Can I just ask a question that came out of that, which is Sheffield Teaching Hospitals reporting as a result of their EPR change?
Yeah.
When are we all going to get full reporting?
So they do fully report. They are have the ability to report. They do send it up nationally. It's a national decision. It wasn't STH's decision not to exclude the numbers. There are some pockets of DQ in there. The numbers are inflated, but they know exactly where they are, and they've brought in companies to do that validation and to get the numbers down to what they think is a reasonable waiting list. It was a national decision not to report.
the view is, just so I understand it, the view is as a result of the EPR, we do some double counting in Sheffield, trying to get to the bottom of it, and that's why it's not really good. Is that right? When you say DQ, data quality is
Data quality, so I think some pathway stops, some areas, so, and I'm going back a few years, so my understanding of the the system that they bought, which is Cerner,
yeah.
is it is absolutely top notch in terms of clinical pathways. When I looked at it in a private providers, the admin functions are fairly basic, and it's an American system.
Yeah.
Being used all over the country, so
Yeah.
lots of trusts do it, but it is actually from an admin perspective a lot harder to administer. So it takes, even though people have done the training and what have you, the way we work in the UK compared to America makes it very difficult for admin teams to cope with the system. And I think that is the challenge that STH are facing. So wrong clock stops, pathways not joining up, the admin bits and pieces of the background, which they are actively working on, and which, as I say, has been is pretty common across the country.
If it does be longer than others, might be being unfair.
I think the fact that they're not allowed to report is a difference from this NHSE regime, where previously I think we would have probably reported.
Okay.
My guess, inflated numbers.
Kevin, okay.
Just on that latter note, Jack, this was a feature of the discussion at the Quippy meeting yesterday, and we recognise that the recovery improvements trajectory has been overseen by the regional team.
Yeah,
we just wanted to be assured at Quippy about that pace of recovery and some assurance over the quality of the data around operational performance, operational delivery, because as Sarah said, if the impact is admin in here, you're always only 1 or 2 keystrokes away from some issues in the patient anyway.
Yeah.
And then thirdly, therefore, are there any impacts upon safety of the patient? So quickly we're looking for some assurance, albeit from the regional oversight.
Thank you.
Yeah, can I make a couple of points around primary care, please, Chair? So great to see in the report, as we know, that increased access to general practice and indeed increased patient satisfaction in increased access to general practice. I think that's been a long journey in itself, but I do see that very much as a positive. The one caveat and risk about that is what David mentioned as part of the Chief Executive's report about reaction and cost general practice to the new contract. So I think that needs some looking after over the course of the next few months. The other positive in there is that after months, years of advocating for how we count dental activity, particularly around urgent care dental activity, it does seem to be recognised nationally that there is a change to the way that is counted and acknowledged. It does mean that we will meet the urgent care dental targets that we were set, and rightly so in my opinion, because I feel we met these a year ago. So I do think that that's great to be recognised. There is a lot of change around dental contracts, general practice contracts, that I think the board would benefit from being cited upon. So I am doing some briefing papers for the exec team, but if that is something that could be really helpful, would be noted here, I think we can have a look at that on a future agenda item.
That'd be really helpful. Thanks.
I thought it was really encouraging to hear about the cancer improvements, albeit in December. And I just wonder if we as commissions have got a sense of whether some of those improvements, particularly the faster diagnosis standard, whether they're sustainable.
So nationally, they would say where you end in December is where you end the year. So we have put the challenge to providers to book that trend, STH specifically. I think the FDS is certainly maintainable. I think there are some pathways that vary with the seasons, like dermatology and different things, where I think we've got a couple of months to go, which is what I said to the regional team, before we're certainly from an STH perspective, whether they're sustainable. I think the other trusts, absolutely, in terms of that sustainability. I think where the other trusts will struggle more is that interdependency with STH, so the likes of histopathology and some of the network stuff and that pathway stuff. So I think the three DGHs have absolutely risen to the challenge and are focused on delivery.
Thank you. Okay. Sarah, thank you. Any other questions on that? Are we going to pick up any other issues around?
David,
do you want to?
So people may be aware that on the 16th of February, there was a national announcement about supplier of packaging for bone cement. Maybe need to pick up on that. And I suppose it's just to brief the board that there will be a temporary halt in their production for a couple of months. And it got managed through EPRR, so you know, Sarah probably was closer to it, but I dipped into it. They have found some alternative providers, producers of the cement, so we are back to business as normal. So it happened, it's been managed, all services are up and running again, and yeah, it's just one of those things that kind of comes out the blue.
We lost about 3 days elective operating, yeah.
I mean, it does feel worrying that we're
So we had one single point,
supplier.
82% of the market held.
I mean, if that was any, and that feels wrong on any basis, to any of us, by the way.
Yeah, I wanted to point out some positive things.
You do that.
Right. Safety perspective, because I think despite all the kind of challenge and change in the system, I still think I was working collectively, and our provider organisations are making some really important patient safety improvements. So take maternity as an example, despite the fact that we've got some of the most deprived or a high proportion of mothers living in some of the most deprived areas in South Yorkshire nationally, and also high proportion of mothers with obesity, which has poor links to outcomes for both mothers and babies. We're still seeing significant improvements across all of our providers in relation to sort of safety standards, reduction in stillbirth, reduction in preterm birth rates, which is we've really battled with for years from a South Yorkshire perspective, and I think just really demonstrates the work that's been done collectively in preparing women for pregnancy, but also that pathway through pregnancy to birth and beyond. And Anthony was kind of describing a little bit around postnatal care and the work that's been done in Doncaster. So that kind of work that's been done in that LMNS space, but also as part of the equity plan, and how vital that is. And we're working with our provider organisations just to look at how we support in making sure we continue that improvement trajectory collectively together. We've also come out really well across all of our providers in the National Maternity Survey, with TRFT being one of the best in the country. So I think they were second top in the country for experience for women across the pathway. So I just think that's some excellent work that's been done in that space. And we have none of our providers that are under any additional scrutiny from NHSE or more widely. So I'd like to say from an NEY perspective, we have some of the safest maternity units in the region, which I think is just tantamount to the partnership work that's been done across the board in that space. And I think, again, kind of just to give a shout out really to the Acute Federation. I think sometimes we kind of challenge around what is the value of some of those spaces, but actually from a quality and safety perspective, the nursing and medical directors have worked collectively across those organisations to really drive forward some areas of improvement, and chose a number of areas to work on together in relation to peer reviews, ensuring equity of processes, just kind of real standardised working across. And I do think we're starting to see that in some of that outcomes data now. So whilst we're still challenged with things like C. diff from a national perspective, just looking at the data, all of the kind of infection areas that we tend to monitor, there's a downward trajectory in relation to the number of cases for all of those. So I just think it's tantamount to the work that they're doing collectively together. And we often focus on the negative rather than some of the really positive stuff that we're seeing.
It's a good point, well made, yes, thank you. Okay, thank you for that. Can we move on to the Sustainability and Green Plan, David, is this you?
Yep, so people may remain, I brought the refreshed Sustainability and Green Plan in July of last year, and one of the actions was to bring back an update, which is what the paper aims to do. Really, the impact of organisational changes is affecting the kind of plan that we had in place, but we have made progress on a number of areas, as you can see in the plan. I suppose the outcome of this is, you know, we maintain a executive lead, which is myself. Currently, we're embedding sustainability into our normal processes of commissioning, contracting and provision. We continue to sort of maintain the reporting through this mechanism at the update today, but through our annual report, and you know, the proposal is that we continue to report back on an annual basis. We are working with the North East Yorkshire region because in the ICB blueprint it was suggested that some of these responsibilities would move to a regional basis, so we are continuing to work with them in the plan of confirming the timeline and the elements of that. So really it was more for information for people than anything else. I wasn't asking for anything from the board, but I'm happy to answer any questions people may have.
David, thank you, Matt. Any questions? David? Item 15, proposal introducing a new commissioning policy, service spec, pricing approach board, ADHD and autism assessment. Sarah, are you leading this?
Yes, I am.
Thank you.
So thanks, Chair. So just to acknowledge first, before we get into the detail, the work that Katie Glebe and Ian Atkinson have done in terms of getting what is a really complex issue into the papers that we produced today. Unfortunately, Ian can't be here, and he is certainly the subject matter expert on this, but I'll give it a go in terms of the paper. So what this is we have known, and we've discussed it here on numerous occasions, we have both the quality and a cost pressure around ADHD in terms of we're spending a lot of money and it's a pretty unregulated market in terms of the amount of providers that we have on the patch. What this does, or what this paper is about having a commissioning policy which sets out very clear quality standards and a pricing methodology for how we would pay our providers. And that's the essence of it in effect. So the paper's here, it has already been through execs and it has been around to AQIA and it has been to turnaround committee. So a number of people around this table will have seen this before. So fundamentally it's asking for two things: one, approval of the commissioning policy, and two, approval of the pricing structure. There are a couple of points to note in terms of the paper then. In terms of the pricing structure, the intention is only to implement that with our private providers. The reason for that is really specific because there will be a national pricing mechanism in a year's time. There are indicative tariffs this year, but what we decided to go with was the West Yorkshire tariffs because they were already operational and we knew this was a transitional year. In terms of the quality standards, you can see it there. It's things like face-to-face, it's things like making sure they've done prescriptions, it's all of the things you'd expect, as I say, a strategic commissioner to build into a strategic into a commissioning policy. In terms of how we implement that, that's also going to be key. And one of the things, and it makes reference to it, is indicative activity plans, i.e. how we manage providers. That's something for us as execs to think about how we do that. We've done it successfully with our independent sectors where RTT was applicable this year. We haven't done that in this setting, so that is something we need to work on. But the recommendation is that we would go for an any willing provider contract anyway, so we wouldn't restrict access to the market, but we would put activity limits on there so we could restrict the finances alongside ensuring that we've got appropriate commissioning standards. And I could talk more because, as I say, you've got lots in terms of the papers, the financial, the market analysis, the bit around the public engagement, which we've covered off to make sure that we're not doing anything with any rules, but it's all there in terms of a pack. And as I say, it's been to several committees before arriving at board.
Yes, and then Mark. I've seen you, Mark. Sorry.
Yeah, so I should add thanks to the Mental Health Collaborative that helped work up these proposals as well, recognising that there are some points of difference between us as commissioners. So obviously we have to work with limited resources, so we put some restrictions on which obviously we will have to review as we go through. This is a new area, it's evolving. What we're proposing is a pragmatic way forward to give the best possible service and access to patients. We are experiencing a lot of over-treatment because of the way we work, so we can prevent that over-treatment so people shouldn't be missing out on what they need. I think in terms of providers, Mark and Toby have flagged up separate to the meeting, the mental health chief executives, that there's potential for market dynamics to come into place where potentially complex patients may be treated by NHS organisations, private organisations may be better equipped to go to the less complex area. So that's something we need to keep an eye on and work through. So we'll monitor that as it comes through. It's something though, Mark, I think we, in terms of us, we do need a control on this, and we need to have a commissioning policy that gives patients what they need within our available resources. But we need to work closely with provider collaborative to understand any unintended consequences that come along as part of this proposal. And then, as Sarah said, this is a transition year as we move into a national approach in 12 months' time. So that's all I wanted to say.
Mark clearly had an interest in this matter, but I'll still.
Yeah, that's what I was going to say up front. So just anything I say has to be taken with the fact that as a provider, I've got an interest in this. So I just want to declare that up front. But I guess first and foremost, absolutely recognise all the hard work that's gone into this. It's an incredible, as we all know, it's an incredibly complex issue with huge challenges. So I'm not, countering that for one moment, and absolutely agree with the need for a policy and all the principles. I think as NHS providers, we do have a couple of concerns with it, how it is at the moment, which particularly I think, as Chris has said, and one of the experiences we've had in West Yorkshire with Right to Choose is by having one, in effect, tariff for both a standard and a complex, I guess, case. What we're seeing is the Right to Choose providers only accepting the simple cases, and therefore the NHS providers getting the more complex cases, which is obviously more time consuming and more costly. So that's an issue. And we had a couple of points around, I guess, maximum wait times and how we rebase funds across the 4 locations as well. So I'm not sure, I guess, what I'm saying in terms of support for this, because I do support the absolute direction of travel. I would like to understand if we've got the opportunity to address in partnership any of the nuances that I've just raised.
I mean, I think there is enough for Chris. Let's keep that open, Mark. I don't think we should see this as signed, sealed, fixed, delivered. Can we keep talking to you? And as we pick up issues, we make sure we address them in year, not just.
Yeah, I think what we'd like to do, we'd like to sign off the policy today if the board's okay with that, and then we're happy to talk and engage with the mental health providers and iterate as appropriate. But we do need to get something in before the 1st of April, including our commission.
Recognise this has been a real pressure penalty this year. We've talked about.
Yeah, so I think it goes back to kind of our previous conversation around the SEND report. So I think this is a point in time. Because actually, if you read the ADHD task force report, there's a lot more in there than just an ADHD assessment, which links into what is coming out from a SEND reform perspective and what will be some of our responsibilities around commissioning from a health perspective and how we work with local authorities and education for provision. So I think it's a point in time bit. So I think the point that kind of Mark raises is really important, that actually we kind of don't do this. This is on the shelf and then that's it. It's to set the reforms will drive us down a different route. I think.
I agree. Okay, that's helpful. Moira, do you want to?
Yeah, thank you. I mean, we've discussed it at Turnaround Commission on the places, and very, very positive about the approach and the huge amount of work that's gone into it. Just taking up the point about case mix. I mean, is there anything within the contracting arrangements that would help to ensure that we don't end up with a situation whereby the private providers take all the straightforward people and the NHS takes all the complicated people, and a bit more of a balanced case mix? That was all.
Can I answer that? And I do get it, but again, if I had my acute head on, hips and knees, that we do hundreds, thousands in the private sector. Since the beginning of time, the complex ones have gone into the acute sector, and it's been, an area of discord. I think what we can do and what we need to do, as Chris's point, is we need to monitor this closely and we need to work with providers, because there is no absolute, you see it very much, as I say, hips and knees are the obvious ones, cataracts are the other ones, where we know the complex stuff goes into the NHS, and it's unfortunately it's a business model, isn't it? And so we have to get this right. We know there's a tariff coming in a year's time. We need to monitor it, but I would say we know this is spend that is out of control for us as well. So we kind of need to put those controls in.
And I'm just conscious of the issue that we already discussed around over-diagnosis of people. So we make sure that people get that supported primary.
The really interesting bit was the bit in Emma's, the bit where the university, the feedback from that and being able to stop it at source is actually the best answer. That's the best way to deal with this. This is just trying to
Patients get the best deal.
Yeah, absolutely, they do.
Thank you.
I've got Kim, I've got Kevin, and I've got Shahida. Kim?
Thank you. I just want to raise consistency because that's something we hear about for attitudes. It's people are using it, so people just feel grateful that they've got that diagnosis, they've got that answered. Others feel I've had a 1 hour consultation and then nothing, and I need treatment and I need further, assessments ongoing, but I'm not getting that under the right attitude. So yeah, it's just my call for consistency.
And that's what the Commission and Policy will do in terms of the standard respect. That's exactly why we're doing this.
Yeah.
Kevin and then Shahida. Kevin.
Thanks, Chair. I mean, we have been a party to the discussion before, and I think these papers do reflect what we've discussed there. So to that extent, I'm supportive. But I think we do have to be careful about the cherry picking, particularly in the differential pricing system. But I think the key for me, which Ramsey Stone was a good transition approach, is this about maintaining market capacity to deal with the demand whilst the new national tariff comes in. But longer term, medium longer term, I would like to think we could talk to the collaborative about the collaborative assuming some sort of commissioning control over these resources so that they can manage the fairness themselves. And that's a medium longer term strategy as part of our approach to commissioning going forward. But I support this as a transition.
Thank you.
I support this paper. I think it's having that set of full control around it is really, really important. I think we've also got to be mindful. I mean, I know there's the SEND reforms and then there's education. Whilst we're in this transitional year, having that wider system conversation is one of the things that's driving some of this demand, particularly in like younger people and young adults and some adults, is that we need a diagnosis. But sometimes the diagnosis isn't about the NHS giving a diagnosis. They're pushed into the NHS because part of the education is, well, if you need special needs assessment or you need additional educational support needs, you're not going to get that until you've got some kind of diagnosis that says you're eligible for it. So it's getting the balance right between, humongous waiting lists within local authority assessments for SEND that, at one point we're absolutely horrendous 3-year waiting list, by which time young people were coming out the other end of school without any support. So there's a SEND reforms, but I think us as the ICB need to be really mindful and cited. We don't lose sight of that, and the kind of differential costing stuff. A lot of that is driven by external factors that aren't necessarily to do with the NHS. So I just think I'm totally in agreement with this, but I think whilst we've got this transition year, we need to push those boundaries about the system conversations of who we're having those conversations with and how that influences this when the national tier comes in the year's time. Because my worry is if it's about trying to be all things for all people, but it's trying to get as much information into this transition year that we can make sense of, that will then give us better control down the line.
So just really agree with some of what Shahida said. I think that, and Kathy, I only know about policy, so it might be different in other places, but I think what we've been trying to do in all of the SEND work we do is as a partnership to say you don't need a diagnosis to get the support. So there's something for me about how maybe in that review that we bring back to try and highlight that, because I think that might, it's not going to stop people wanting to get a diagnosis, but I think if we're able to support people better before that, it might mean that actually we're kind of not driving the demand as much as it seems to be.
Well, I think we are, I think you're right, really.
I think we are.
This drives demand. This is I see this as a stopgap to get us some control there.
Yeah.
There's a more, particularly on set, a much more fundamental. It stops the system driving the demand. You do not get help unless you get formal diagnosis. It's not a helpful position.
No.
Kim and then Kathy, and then we'll finish. Kim.
Thanks. I just wanted to come in on the send issue. Rotherham has a different arrangement to the rest of South Yorkshire, so that needs to be taken into account when you're thinking about what that might look like.
I mean, in fact, when it comes back, it'd be helpful we have that discussion.
Yeah.
Kathy?
Yeah, I think the point you've just made and that Katie's made is one of the places where we can really do some work collectively together, because actually if you look at the ADHD task force document, assessment's really small part of it. It's all the other stuff which you don't need an assessment for, actually is around supported provision in school without an assessment. That's the same for SEND, and there are many schools that have plans in place without diagnosis, but it's a mixed economy.
Really helpful conversation. People happy to go forward with this as it is today. Two things. One is we want to keep talking to the providers and keep an eye on what is going on in the market, and recognise also this is a transition. My worry is I wouldn't wait for the centre to deliver something next year, but maybe I'm a cynic. Okay. Thank you, everybody. That's helpful. Chris, running cost reduction. I don't know whether you wanted to add anything to what you said in your chief exec's report.
No, so this is, we're calling it running cost reductions here. This is the organisational changes that we gave earlier on, Chair. So I'll just be duplicating, so I just refer people to the written report.
Okay. Okay, thank you.
Just to reiterate, we'll be implementing a model on the 1st of July that fits within the £19.40 running cost allocation.
And that's implementing it 3 months later than we were supposed to implement it, just to make clear to what. Well, it's important that we tell the board that we thought we were told to do it. Now, I don't think it was physically possible for us to do that.
Legally.
Given we've done legally possible, but it is actually what the department were expecting us to do. Okay, financial delivery month 10 report, Roxana. Welcome, nice to see you.
Thank you. Report's read, but I will take you through some key points in the report, if that's okay.
Yeah.
So, in terms of the year-to-date month 10 position, we are behind plan, but that is in line with reported trajectory that the board has kind of previously reported. We still have not received Q4 deficit support funding, so again, that's important in terms of understanding the ICB's year-end forecast position. We are still anticipating a year-end position of 39.8 million as reported in the Chief Exec report, and we are working, clearly we're in March now, we're just working through month 11 position, but we are absolutely working on the assumption that we will deliver against that reported position for the year-end. The board will be aware that we entered into triple lock in terms of NHS England and submitting a forecast change protocol through NHS England colleagues. So that has introduced some further grip and control into the ICB around expenditure approval. So that is really important as well to note. The report sets out as well that we received £15.5 million of funding to support our running cost reduction, so that's the organisational change. Estimated costs are in the region of about 23 million in terms of redundancy costs for the ICB at the moment, based on the number of people who need to exit the organisation. And we have mitigated the £7.5 million gap between the allocation from NHS England and the £23 million estimate that's included in the forecast. So that's not contributing to worsening the ICB's financial position. It's really important to know that here. We have delivered efficiency, 100% efficiency within the ICB during 25-26. So 96 million have been delivered, and that's included in your report. And the cost pressures that we've discussed through numbers of reports here today around right to choose remain the same, continuing healthcare, right to choose, around weight management and ADHD, ASD. So they remain the cost pressures overall. Nothing has changed in terms of the movement of those positions, and kind of those positions are included in the pack. Just to note the system position, so that's the ICB position. In terms of overall the system position, all providers, with the exception of Rotherham Trust, are delivering against their plan. Rotherham Trust have entered into the forecast change protocol, so we'll be reporting a 6 million deficit off plan. So that's just to know, and Rotherham are also under-delivering on their efficiency programme against that. So I think that's probably one of the contributing factors for the Rotherham Trust, is that they're 3 million off plan in terms of their efficiency programme. So overall system efficiency is in the region of about 271 million in 25-26. But we're not anticipating at this point any further off track in terms of the provider positions. So that, in a nutshell, is the 25-26 financial position.
Thanks, Roxanne. That's consistent with conversations we've had previously in this place. Any questions on that? Roxanne, thank you for that. Operational financial plan. Sorry, Moira, I'm sorry, I did not see your hand.
It's all right.
I need to wear my glasses.
Two very quick questions. Yes, we've been through it in thick and other places. I'm working on the assumption we're not going to get any deficits of funding for quarter four unless somebody tells me differently. Yeah, okay, thanks. And the other thing I was just going to pick up, which was the point that Sarah made earlier about overall the NHS being in balance, which is interesting, challenging, given, you know, our position. I know we're not alone, basically. So
there was some money centrally, wasn't there, Roxanne? Which
right.
NHS England have recently announced some kind of national resource that will effectively offset the deficits that have been reported through the forecast change protocol. So they've used that funding to therefore kind of offset any mitigation.
It's balanced at the centre, not in every place. I think it's a fair description.
So we're very keen to stress it wasn't money that was directed for patient care.
Thank you for that clarification.
Okay, Roxanne, thank you. Operational financial plan.
Okay, so again, this is thanks, Chair. So just briefly then, the documents you've got there in terms of the commission intentions, the operational plan and the finance plan are all documents that have been previously circulated for yourselves in terms of FIC and the board, the board committee meeting prior to submission. So just in terms of highlights then, so we submitted on the 12th of February, as everybody knows. The only change in terms of the operational standards were that STH have said they're going to be compliant on UEC by March 2027, which previously they didn't do that. In terms of the next steps, we had two providers that had to resubmit plans on the 2nd of March, which were around financial reasons. But the expectation is there will be a further submission on the 17th of March, and that's probably around some challenges around the RTT position that has been submitted by providers, certainly in the northeastern Yorkshire. None of our trusts were compliant on RTT, so there are challenges going in around the level of productivity ambition that that's expected in the plans for next year. In terms of the commission intentions, we're currently working through how we turn those into contracted intentions, and the next big job will be to negotiate the contracts and make sure they marry what was in the planning submissions. So that is playing through the planning oversight group. That is still continuing to meet weekly. As I say, there's nothing in there that you haven't already seen before, certainly from an ops or commission intentions perspective.
Okay. Any questions on that? Again, I think we've been through most of that. Can we pick up then, that leads us into the financial plan for 2027, Roxanne?
Yeah,
through that?
yeah, that's fine. So as the board will be aware, we submitted a balanced financial plan, which does assume deficit support funding through the 3 years on a phased approach, which is included within the paper, and delivery of efficiency through each of the financial years. It is important to note that we are carrying from 25-26 into next year an underlying deficit position, which is kind of the contributing factor of 118 million, which is obviously means our efficiency programme into next year is in the region of about £119.5 million. the detail that's included in the pack today suggests that 69 million of that has been identified through various programmes, and 50 million remains unidentified. But we are working across kind of the organisation really to kind of work through exactly what that might need to look like, and how we might put some stretch out into kind of different areas of the organisation in terms of commissioning intentions, in terms of decommissioning decisions, etc. So we are kind of working through that with the view that that will be taken into the Finance and Investment Committee during March, and then into board on the, I think it's the 1st of April, the next board meeting that will then see the final plan position. It's fair to say that there's been significant amounts of work gone into the financial plan in terms of the work we've done around zero-based budgeting, kind of grip and control, commissioning intentions and quick schemes. So we are working really closely with our exec colleagues around kind of how plans are developed and are robust, so that we can have clearly some confidence in the level of delivery as we move forward into next financial year. It is important as well just to note that we do have some alignment gaps in terms of our provider contracts as we sit here today. That totals £10 million, and again that's included in the pack. So it's Barnsley Hospital, Doncaster and Ardash are the three areas where we're misaligned at the moment. Conversations are ongoing with those individual organisations to kind of work through what that might mean in terms of implications for both the ICB and other potential providers, given that we undertook an exercise during late summer last year around that was referred to as deconstructing the blocks, which showed some kind of unders and overs in terms of funding arrangements. So we quite clearly have got some real clear work streams that we kind of need to take forward as an organisation as well as across the system, before we can absolutely understand how funds are flowing from an ICB perspective, and if they are sat in the correct place in terms of funding the correct levels of activity in each of our providers. So I think that's kind of where we are on that. In terms of system submission, I think Sarah's already confirmed. I think most of our providers now, with the exception of two, I think, as I sit here today, have submitted balance plans in terms of their position. I think Doncaster remains the one that's still outstanding, and I believe Sheffield Health Partnership University. So those, but it's very, very small variance for the Sheffield position. The Doncaster one is the one that is fairly significant, and conversations again remain ongoing with that particular provider with NHS England colleagues. So that's kind of where we are. Not a final position, I have to say. It is still a work in progress, and we are still working through what some of the numbers kind of are and how we then need to develop the plans.
Thanks, Chris.
So thanks, Roxanne, and just great to Lee and the finance team for doing a great job. In terms of context, in terms of the gap for us as a region, our gap is probably, hundreds of millions, whereas our gap as an ICB is about 35 million, isn't it? So in terms of we have by far the lowest gap, it still doesn't mean it's not incredibly challenging and working through, and there's never enough resources in the system as we go through. The expectation from NHS England colleagues is that we will resolve all those issues in the next couple of weeks to get to a 1st of April position. For South Yorkshire, we're heading in the right direction. We need to come up with a plan with NHS England for Doncaster and Bassett-Law. That's the key thing. That's the big outstanding issue. And what we're finding in the other areas are some large numbers within providers, not within the ICBs, it's in the providers. So that's where we're at. The positive is we're here in early March, and we're going through, and we're just going through. But it's going to be a tough year, and then the next year after is only a 2% increase as well in terms of the financial settlement. So just as we're heading into the next 2-3 year cycle, we're going to be very much in efficiency. The last thing I'm just going to say is providers are running at CIPs of an average around 6%. Yeah. They're looking at an average of 2% workforce reductions. This is different. So just to flag that up.
Yes, so I was talking to all the chairs, they're all looking at redundancy programmes in each of the trusts as an example or a proxy of how challenging this has become. David?
I suppose as a board, I do think we need to be careful about using things like risk and challenge. I mean, this is truly heroic to achieve the outcomes of the balance plan on this. And I think we should acknowledge as a board that that's what we're putting in, because we're signed up to this and we've done it previously, which we set ourselves a task that actually isn't beyond what is humanly possible. And I use the word heroic on that basis. So I just want to make that point because it isn't just a challenge, it's beyond that.
Kevin, and then I'll come back to actually what we're approving now, because it's actually quite important.
Yeah. In our previous discussions, both around the board table and other fora, we've agreed to demonstrate our ambition to break even next year. There's no reason for that to change. And recognise the tremendous amount of detailed hard work that's got the plan to this stage. I suppose it's David's point, but couched in other terms, this is not yet a credible plan to deliver that ambition of break even. And it's now first week in March. So I guess I've got other questions, but the fundamental one, what is going to change? Not least of which there's a £50 million hole.
Yes.
So what is, and we've known about the hole for some time. So this is not new. We've sharpened up our sense of what the size of the hole is, but it's still a big challenge. So what is going to happen in the next 2 or 3 weeks as we hit the new financial year that's going to convert this into what these are my words, nobody else's, a credible plan?
So in terms of, things that move in terms of the executive team working through, the number is, the gap is tricky all the time. And our expectation is, I think we're coming to our finance and investment committee to give the latest before we come to the 24th.
Turn around on the 24th.
Turn around on the 24th. So we are working on it. The plans are being built up as we speak. Will it be challenging? Absolutely, yes.
Can I just tell you what we've agreed to today? I think, given the 24th, we're actually being asked to agree to first 2 bits of this, which is the Commission Intentions Operating Plan. Our financial plan comes back on the 24th of turnaround. We asked, we being non-execs, for more detail to give us more sense of the right direction. Not that we'd get copper bottoms, but we'd get more confidence in it. So formally, I'm asking you to put the first 2 bits. Quite important. The last bit, we've got another go at this before it comes to the board on the 1st of April, on the 24th, which is turnaround. I think that's the date, 25th.
And as Roxana explained, there's lots of moving parts because how we deal with our provider contracts very much depends on what the quantum is. So that's why it's going to take a few weeks to work through.
So I absolutely get that, Chair, not least with the Chair.
Also,
there is something about getting the assurance of the progress.
That's part of what I think was
March, because I think those moving parts are significant.
Yes.
And it just feels as though we're some way off yet with a very short period of time to actually address the gap, to convert it into a credible plan. So it's about measuring our own expectations, but getting the assurance of
I think what the way they're going to get, we need more confidence at the 24th.
Yeah.
Don't expect copper bottomed, but I expect more confidence. Sorry.
Yeah, I was just going to explain some of the work that is ongoing. So there's lots of work going into kind of how we prioritise our commissioning intentions moving forward in terms of what are our staff physically going to be working on moving forward that will absolutely contribute to financial efficiency as we move forward through 26, 27 and 27, 28. So we're trying to develop a prioritisation framework to help the workforce in terms of understanding kind of scale and impact, because actually we need to think big and think different in terms of kind of moving things forward, Kevin. So I think we are trying to get into that stage, recognising, of course, we've got the organisational change in the middle of all of this, which is likely to have some impact. We do need to kind of we're ploughing ahead on the assumption that we're going to have something that will allow our staff to take forward our priorities as an organisation.
And just to test your patience further, Chair, if I haven't taken the fire up already, the comments you've made around the bigger and more challenging actions, I think need to be writ large going forward, because my fear, and I'm sort of reflecting upon my experience at Quality Committee yesterday, is that the pips are starting to squeeze in terms of our approach to zero-based budgeting. And I have some emerging concerns from yesterday's meeting about how that, combined with our RCA reduction, are starting to see it impacting upon quality and our ability to actually do our maintain our statutory duties. Won't go into the detail because that'll surface through escalation. But I think we've got to the point where we do need to start looking. It's going back to the earlier discussion about our strategic commissioning approach. We need to start identifying those big changes that are going to contribute to this, not only, maybe less so this year, but offer the structure for future years. And yet I'm struggling to see in all of this where we've got the capacity and indeed capability to get into that bigger transformational space. So I will shut up next. I'm taking it over the line. Sure.
Just very briefly to support Roxana. So we've got the first prioritisation panel this afternoon, and Roxana, I've been asked whether I chair that, and Roxana's part of that group. So I think that is the process to take forward, and that will hold us in good stead, medium to longer term. We will obviously consider this to sort of short term in that time.
Okay, people come to it. I've actually to do two things today, which is support both the commissioning intentions and operating plan, not yet the financial plan. We're going to have a go at that at the end of 25th. We're now 25th of March. People comfortable with that?
Yeah, it's down.
Thank you. Freedom to speak up, update.
Yeah, our annual update on Freedom to Speak Up. So just to remind you, I know you all know this, but in case you forgot, so Claire Wilson's our Freedom to Speak Up guardian. I'm the Freedom to Speak Exec lead, and Leslie Devell is the non-executive lead Freedom to Speak Up. We are all trained by the National Guardian's Office. The National Guardian's Office has also been abolished, and it will cease to operate from May 2026, which is a real problem for us because we get all our training for their door reporting through there. So we were awaiting further guidance if anything will replace that. I have to say it's an excellent offering, and we're encouraging all primary care providers to try and use to get the free training before the end of May as well. So I've sent a note out to all primary care to try and take advantage of that. Just a couple of things to pick up. So we do our sort of activity report for the year. So in Q1 2025 to date, we've had 5 freedom to speak up concerns have been raised. 2 were internal to the ICB and 3 were external. We're not accountable for external inquiries, but we quite often get people from primary care where arrangements aren't particularly clear in a practice, where we give advice and signpost to people, and then if it's necessary, we'll refer to appropriate commissioning teams as well. So we try to be as helpful as possible, but in terms of what we're actually accountable for, we are only accountable for Speak Up for the 800 staff who currently work in the ICB. But obviously, we try to be as helpful as possible. Again, it just item 4 in the page talks about the National Guardian's Office, and it will be no longer be requiring guidance with transition to NHS England, which is the way further information on that. But very helpfully, we had an audit from 360 on our freedom to speak arrangements, which generally were really helpful. They tried to look at best practice, which you tend to get best practice in hospital foundation trusts because you have freedom to speak teams, and it's sort of like a well-oiled machine. It's sometimes quite hard to then apply to a commissioning organisation. Sometimes when we went through the best practice, we had to discuss how it's meant. But I think we've got to a point where we'll have a case tracker which is aligned to how the secondary care trust report. We'll try to have an annual plan for increasing awareness of, and that's something you and Gordon have been helping us with. So, we have freedom to speak up. We have all staff meetings. We have the areas we can use to promote in terms of freedom to speak up. So we'll try to put that in the plan. And then our freedom to speak up policy, when we first signed it off as a board, it's evolved, so we've updated the policy just to reflect national guidance and best practice, but nothing sort of material in that change. But attached is the guidance for what we should expect from freedom to speak up. So I would record that I have asked all members of the board to familiarise themselves with the guidance. That would be much appreciated. If you'll, at your leisure, you could read that guidance, that would be very helpful. That's it.
Any questions on freedom to speak up? Yes, thank you. Corporate assurance report.
Thanks. Excuse me. Thanks, Chair. I'll take the report as read, gives an update on the corporate assurance activities during the periods in the last report. There are three things I'd just like to tease out. The first is, to the Chair's delight, we have had a further utilisation of the corporate seal. So I need to report that to the board.
And I'm doing another one this afternoon. Oh, it's tomorrow. I mean, the bloody ceiling. This.
I'm just recording in advance your rant. We do know where you're coming from, and we understand.
And the reason for our delight and excitement is because of and it's absolutely aligned to the family care capital build work that's been reported throughout the last few years. So it's symptomatic of those developments coming to a conclusion, so that contracts are being signed and sealed. The second item I just wanted to flag is there's a brief update for the board in public on the processes that have been adopted over the last year around the fit for persons regulations. I won't regale you with the detail that's in the report. And the third item is just to signal to the board the necessary governance changes that we'll need to implement between April and July to reflect the changes subject to the approval next week of the consultation outcome reports. So just to recap, there will need to be a series of changes to the ICB's composition and constitution, to the committee structures after due consideration and discussion by the board and suggested in the April development session. The terms of reference for corporate committees will need to be revised. Delegated and appointed roles will need to be reassigned and appointed to in the period, and there'll also need to be an update of the ICB scheme of reservation and delegation. So that will need to continue a bit of a governance pathway, which will run between now and July board meeting.
So we envisage the April informal will take you through what that looks like. Then needs to be formally approved by NHSE because there are constitution changes like how many partner members we have, that kind of stuff. So it might need us to take the last 10 minutes of the informal to a formal to allow it to pass that to go to NHSE. And every ICB is doing an exercise that looks a bit like this. Any questions on that? Thank you. Items for information. Are they okay? Okay, we have no private meeting following, so that's the end of the meeting. You have